So really a great panel. Thank you very much for those interesting presentations and also for keeping us well on time. That's very much appreciated. We now have about 25 minutes or so for discussion, and I will begin with discussions and comments from the Roundtable members. But if we do have time, I'll broaden the questions from those who are also in the room. Please identify yourself as you ask a question, maybe even put up the place card so I can see who you are. Let me start and open this up for some perhaps discussion, because I'm intrigued by some of the presentations regarding quality and performance measures. George, I too look at the delivery of quality care as being the foundation for that being the National Quality Strategy, which encompasses the three aims of better care, improving the health of the community and the population, and affordable care. And in addition, the learning health system, which puts in place performance improvement and the feedback loop and a robust IT infrastructure. And without health literacy, I don't think either of those are achievable. I think we can all agree with that around the table. And Russell, I also agree that the metrics you pointed out are really very helpful. Perhaps, though, and they're good process measures that really will determine whether or not the process of health literacy is in place in multiple organizations. But do we have metrics to demonstrate whether we are actually improved? Have we demonstrated improvement in health literacy? And therefore, do we need outcome measures to demonstrate that? To answer the question, have we improved, identify gaps in care, and then put in place those things that can definitely improve those gaps. So should the Roundtable engage in that kind of discussion, do you think? Would you think that would be productive? Perhaps you and George can answer some of those questions.
Yeah, thank you for the question. I think the Roundtable should encourage and move forward with pushing for organizations to measure organizational health literacy. And, you know, the ideal thing would be to work with organizations to do it in a robust way that optimizes opportunity for evaluation. You know, I think this is a challenge with a lot of quality improvement work in general, where groups sort of rush in and start measuring and doing stuff, and it's important. You know, that is one of the values of quality improvement, but you have to do that with a robust evaluation plan in mind. So I think anything that we could do to help an organization think through what should you be measuring at baseline, then, you know, do your quality improvement work, do your measurement and assessment, but then there has to be some measurement post that you're going to use to drive performance. And we need to make sure that it's set up in a robust way so you can truly try to link the changes that you've made in addressing organizational health literacy to improved outcomes. And so, you know, you need to think through that process. There's proximal outcomes you can measure, just in terms of like what % of providers are aware or were trained to address health literacy, what % of materials at your site are health literacy. But ideally, we do want to see the link all the way to improved patient satisfaction, patient self-care behaviors, and patient health. I mean, ultimately, we need to make that link that addressing organizational health literacy does ultimately lead to improved patient health outcomes. And the last thing I'll say is, I also think that's where the importance of getting multiple sites to use the same metrics is going to be really important, because from a measurement perspective, you're going to have a lot more power to look at the predictive utility of measuring and addressing health literacy when it's being done by multiple organizations across the nation.
George?
Yeah, I think, and I thank Dr. Rothman's presentation was very, very helpful, and the paper very, very helpful in describing where we are with measurement and this topic. And I very much agree with your conclusion, the one you just made and the one you made in your presentation, that until you get organizations using, you know, a subset that's consistent and with experience that they can share to one another, we're not quite at the point where we've got broad scale use. So we're early in this process. A lot of the tools that have been referenced are pretty labor intensive to actually deploy in an organization. And particularly if you want to deploy it repetitively to compare assessments at time 1 with time 2, which is sort of the essence of quality improvement. And a lot of work, as you point out, needs to be done in order to abstract elements of these various tools for particular organizations to use. So we're early in the process. I think it's reflective of the fact that we don't have measures available to advance to, say, the National Quality Forum or other regulatory or accountability organizations for use, broad use and accountability that relate specifically to health literacy or these issues. So that doesn't mean that we should be discouraged. It just means that we've got a long ways to go. The second is this issue that I try to raise in my talk with respect is we need to be aware that health literacy is an issue in different ways for different populations in different geographies. So although we have the national sort of survey about how prevalent low literacy is and limited health literacy is, and we have the separate body of knowledge about how that relates to outcomes, that information needs to be repeated at a local level and at an organizational level to get the attention of people to focus on it. So there's that function of measurement that's more about the environmental, the personalization of it, say in Minnesota where my organization is, or in New Mexico where I now live, that's really critical to getting attention and surveillance over time. And so that's a different role for measurement that I think also needs attention. And those components of measurement are critical to getting organizations to devote resources and actually improving things. And so I think this is a critical sort of issue.
Michael, do you have a comment?
Yeah, thank you. So, you know, the other side, the other arrow, the individual side, I think is going to also need to be there in order to prove the OHL side. In part, just building in the individual side analysis into the PDSA cycle to see, in fact, if the interventions are having an effect on the disparities we want to look at. So, I don't think this can happen, you know, just all on the OHL side. In the end, I think you hinted to this, Russell, but you know, in the end, we're going to have to prove to people that we're actually decreasing these disparities.
I see we have Katina, Ruth, and Rima in the queue. I think we can probably handle that.
I'm Katina O'Leary. I want to say, first, I really appreciate this thoughtful panel. I'm particularly interested in the discussion on the data on measures. There's a lot of information about what measures people use, and you gave a pretty nice description about all of the data surrounding that, but we don't talk too much about how people use them. And you made comments about how exciting it is to see people hiring internal staff to start to evaluate their things. I'm interested in what we think about the internal bias with asking people to evaluate themselves on things that are so sensitive and complicated, what we know about that, how it works, how it functions in a place, and how we put that together.
I think it's a very important challenge with some of the organizational health literacy assessment tools that are out there now. And that's why I sort of endorse that. I think the tools that measure from multiple different perspectives are probably more robust. So not just getting the perspective of the organization, but also of providers and of patients. The other, there is subjectivity in a lot of the measures that are out there. They just, you saw some of the questions. They just ask, how well does your organization, you know, do this? And there hasn't been a lot of work to truly assess the validity of those measures. So I think your concern about bias is an important one. There are some measures out there that have tried to be a little bit more objective by looking for hard numbers, like what % of your materials or health literacy, or what % of your staff have been trained. But even there, if the definition is not clearly defined, you can say, well, yeah, we did a 20-minute training, therefore all of our staff has been trained. So I think there's still a lot of work that needs to be done to really validate some of the measures that are out there, or to develop a measure that can truly be used both for measurement and for improvement. Thank you.
Along with the maturing of the measures, though, it's really high time to engage with accrediting organizations that actually serve in this function to be the outside voices and outside, eyes. So it's not, so it won't always be the fox guarding the chickens.
Thank you. Ruth?
Thank you, guys. Ruth Parker. So I wanted to ask you all about who you see might be partners in the space that surrounds sort of three terms that I'll call cousins. Number 10 in the attribute list that relates to cost, and that seems to yet be out there somewhere hanging and not yet well addressed. It's been referred to as the business case as well. So we've got business case, we've got cost, and then we have what may be a patient-centered or even community-centered concept of affordability, which happens to be in the title of the new law. So when we think about cost, transparency, the business case, cost, affordability, and health literacy, I'd like to know who's in that space and what partners there are and where the field might go as we look to think of the future and how this can end up affecting what's going on in our country and what happens to our people.
Great question. I wish I had a robust answer for you. I think the government is obviously the biggest potential partner. They're a huge payer, and in particular Medicare, has started to get into transparency of costs, as many of us are aware who are physicians. There's obviously a lot of work that needs to be done there in terms of improving the clarity of the message around some of those cost issues. But I think clearly the government has to be an important partner. But there are private organizations that are getting into the cost space. There's the company with the woman who had been at Stanford and left early and started her own company around transparency of cost for medications. Do people know who I'm referring to? It was in the New York Times a few weeks ago. It's like one of the fastest growing companies around providing patients direct information about cost of medications. So I think there are some groups that are really starting to get into the space. I'd welcome comment from others.
So you may not know this about me or Health Partners, but we've been very active in terms of promoting measures of cost of care. I actually have a total cost of care measure. If you go to healthpartners.com/TCOC, you'll see some working papers for how you measure total cost of care as it applies to healthcare systems. The reason there's not many measures in the cost column for health literacy and in general, this goes far beyond health literacy, is that there's a resistance to describing cost of care from a number of sources that don't want us to be looking at providing services over cost, in other words, efficiently, because the preferred state would be to have the freedom to deliver quality care regardless of the cost. Let me put it that way. So there are a number of organized segments that do that. The government is a little bit limited in that regard because they have to respond to some of the politics around that, and so for PCORI, for example, is prohibited in terms of looking at patient-centered. Some of their comparative effectiveness research, they're prohibited from looking at cost. So there's some private organizations that are doing that. Some accrediting organizations have been looking at that. The NCQA has looked at it. The NQF has had a group that's looked at cost measures And there's increased emphasis on that. I think there's an emerging appreciation for the fact that as, again, these organizations are formed through the Accountable Care Act and have to consider not only the performance for populations of people, but also the cost involved in terms of providing those services, I think more organizations will become interested in describing it accurately. So those would be a couple comments I'd have.
I'm going to correct myself and say that I was referring to Elizabeth Holmes. The company is Theranos, and it's around cost transparency of lab tests. And it's growing like crazy. You may want to take a look.
Ruth, that's a particularly good question. We have not been shy since the ACP days in getting people involved in this issue. And a public-private partnership here is obviously a way to look. We certainly can look at other organizations that have done this in this area. George identified two that are particularly interested, NQF, NCQA, but perhaps Brookings or RWJ or others of that sort who have addressed some of these issues in the past would also be interested. So we do have a conversation coming. Rima?
Thank you. I want to return just briefly to the measurement issue in two ways. One, picking up on something that George mentioned, that transformation that you'd like to see in quality improvement measures, moving from the patient to individuals. A lot of our colleagues in Europe are moving from the patient to individuals to communities, and they're including community measures and community assessments of systems of institutions, and that's something that we might want to consider as well. And then I'd like to mention what very often is the elephant in the room in regard to other measures. We have very good measures now, multiple measures, of patient skills or deficits, and the link between those and outcomes. We have fairly robust measures, they're getting better, of materials. We can assess materials, as we talked about this morning, in regard to drug labels, and we are on the verge of looking at improved materials and health outcomes. What we have not developed and what we have not done, and this is the elephant in the room, is that we have not assessed health professionals. Both clinicians and those of us like me in public health and our ability to communicate. And indeed, we need measures of the communication skills of health professionals and health outcomes. And that seems to be lacking. And I would venture a guess that we cannot easily move ahead with assessments of institutions until we have those measures and assessments of the professionals working within the institutions.
A very good point and something we should not ignore. Yes.
I just think it's a fabulous comment. It's a fabulous comment, Rima. I just want to point out it's incredibly far from where we are right now. Like it's like, but just as an example, from the time I graduated residency to now, I don't think I'm motivated to tell you how many years that is, but it hasn't happened not even once has anybody observed or given me any feedback about anything I've done in a room with a patient. It's not part of the culture. And so, in fact, it'd be great, but there's a big road to hoe.
So you should come work for Health Partners. Anyway, a couple points you made. I totally agree with your point about moving from patients to individuals to communities, which I should have added. And the other point I'd make in that regard is that with respect to strategies, we have the universal precaution strategy, but in the final analysis, it's a blunt strategy. And it's a very useful strategy, but I think you can build upon that and tailor your approach to individuals based on their health literacy skills. And I think the information technologies will allow us to do that. So for example, if you have a clinic in a neighborhood where you have a demographic population, where you know that there's a literacy challenge, you can arrange your services differently in order to improve, say, preventive services or chronic disease care. Or you can tailor, I think, by individual as well, as we begin to have the ability to do that. But we need first a tool to be able to know where people stand with respect to their individual preferences, values, as well as skills and capabilities.
And I would just say, I think, as you know, there are communication skills tools out there. There's Greg McCool's community CAT tool, and there's Deborah Roeder's re-asked if you want to like audio tape conversations, but they tend to be very labor intensive. So I think it's challenging to administer them broadly. I mean, at least some of them are, such as Greg McCool's tool, things where patients can at least write about what their experience was with the communication, so not just from the provider's perspective. I think that there is some focus on specifically like the physician or key provider in the room and their communication skills, but there's very little, if anything, out there around all of the other people that a patient may interact with when they come into a health system, whether it's the tech who puts them in the room or the nurse who comes at the end to talk to them about their meds. We don't look at it from a full system level. We tend to still get down to just the one patient, one provider level. So I think there is a lot of opportunity there to look at the communication, not just of the physician, but all of the different members of the healthcare team or the healthcare environment that are interacting with the patient or their family.
So Rima, don't give up on that one. We're encroaching on lunch. I see two additional panel members who would like to have, so if we can do that very briefly, that would be good. Betsy and Michael.
Just want to follow up on the point about the team as a whole. I think that we don't want to worry about an individual patient having to have many skills in order to use the health system. And I think we probably need to look at the whole team interacting with the patient rather than identifying that every member of the team has to be a great communicator, because I'm not sure that we can add that on to the other skills we may need those people to perform in order to deliver high-quality health care.
Michael?
Michael Valair, Institute for Healthcare Advancement. Dr. Wu, thanks very much for this study, and thanks to Ruth and our missing colleague today, Kavita, for the work on this process for identifying and capturing some of these best practices. We're doing some work in this space as well. In the outreach, education, and utilization model, there's a piece I think that we need to make sure we don't lose, which is that retention piece, just to make sure that that's a whole iterative process and we capture people, don't let them slip back through the cracks. We did a project with some local folks in California capturing some best practices, and we have a curriculum for that, so I'd love to share that with you. Also on the this notion of informing people about how to use their health insurance, I think there's actually a little deeper dive that we can do, and we're doing some work on this, which is to look at that subpopulation of the chronically uninsured, those who have never had health insurance, and look at those behaviors that set of individuals have and have used as coping for so long in terms of how they deal with illness, injury, and how we help crosswalk them from those behaviors into you are now insured. How do you use this? But providing that actual crosswalk from those chronic behaviors into now that you're part of this great community of the insured, and how you use that. And we're doing some work in that area, so I'd love to have a further conversation with you. Thank you very much for that work.
Just one brief response.
Yeah, just a brief thing. It actually ties together several of these issues, which is that we're in an awkward time, because if we were in a population management mode, if we were in an ACO, in fact, actually, you could get Ruth's estranged cousins together. You maybe that people to care about some of those issues, and you could also worry, to manage the issue of loss of capture. They're yours. You can't lose them. So I actually hope to be able to practice in a population management kind of setting, but I'm not there yet.
There's an application, George. Thank you all very much. This has been a very stimulating time.